And right now, I would like to give um, the opportunity to Professor Hayat to give his lecture. Thank you very much. Oh yeah, by reciting basmalah together. Bismillahirrahmanirrahim. Okay.
Sebentar.
We also ask in different countries. So this is nothing that is very unique for Indonesia. So we provide the methods. You have to provide the data, and the answers are for Indonesia. So this is typical for Indonesia, but the methods that we are using in these partnerships are the same. And so hospital partnerships in this way means that we exchange the methods. We are not just exchanging results, we exchange especially the methods. And these needs need to be addressed, and you need to discuss, especially in a group. If you have 8 different master courses here, you have to discuss with each other what is your perspective, what is my perspective, and bring these perspectives together. And this is something that is really fruitful. This is what I really want to encourage you, because you are the ones who have to develop the system further. I will retire in some years, but you have to develop it further. So talk to each other about the perspectives on what you are achieving and what the system is doing right now. Okay, now we have to look where we are. Yeah, go back. So this is actually the example that I briefly mentioned. So we were looking at how is Indonesia actually organized regarding healthcare. And we used the methods that I mentioned, complex statistical analysis, and we could identify how the people are taking, and this was the cancer care, because I'm a cancer specialist, so this was for cancer care, how they use the options that you have. So how they use the BPJS coverage system if they have cancer. And then we could see that a large number of the cancer patients are changing the provinces. They are going from their home province to another one to get the cancer treatment done. In Jogja, for example, and this you will see on the next slide, Jogja is one of the, we call it the recipients of this migration. You have actually in Indonesia, you have only 2 provinces who take care on all the other ones, all the surroundings. And one is Jakarta, which would you probably expect, and the other one is the province of Jogja. I mean, you can be proud, but this is not good. I fully understand that you are proud, but then the system is not working. Then everything is very complicated to organize here for you because you are completely overcrowded, because you get all the patients from everywhere. You also get patients who do not need the special care that you can provide here. So this is one of the messages that I want to give you. You have to discuss, especially with each professional group, you have to discuss what is the best way to provide the care. And migrating a long way will, on one side, will encourage only the ones who can afford the travel. So the other ones are not getting treated properly. And you will use the expensive options that you have here. Advanced care is always expensive, but not all patients need advanced care. So you have to make a good selection. Who should travel or who should get the advanced care and who we can treat in primary care. And for example, follow-up investigations, just look if everything is fine, can be done in primary care. So you don't need specialized care for follow-up treatment. And this is one of the lessons that we learned. So cancer care needs to be organized in a way that everyone is doing, and that we have the patients in the right place where they need the care, where they get the care that they need. So the next one, please. I want to share with you these cancer examples because I'm familiar, but you can do the same analysis and the same argument. Someone is on a boat or in a storm. Okay, so back to the back to the presentation. The next one. Next one. Yeah. Okay, why is it so important for Indonesia to look at cancer? Right now, actually, you could argue, and you would be right, the number of cancer cases in Indonesia is still relatively low compared to internationally to look in other countries. The number of cancer cases is relatively low. And could you open this one? This one, no, from current slide. From current slide, this one. So look here, at least the ones who are here in the audience can see. Look, here is Indonesia, and if you compare the color, Germany has very much the same color. So this means everything is fine for Indonesia. The numbers are comparable to what we have in Germany, and Germany is always the country that you are looking for. So everything is fine, just go home. Yes, could be, but it's not really the truth. The next one, please. Yeah. Still, here, you see the mortality rates. And this is actually the change in mortality rates. And again, there is only a slight increase. Here, this is a slight increase. Germany has a slight increase in mortality rate. Indonesia has only a slight increase. What are you talking about? So go home. Cancer is not important for Indonesia. You are still right. And now I have the next slide, and now I show you why it is important anyway. The next, please. Yeah. Look at the demographic development. And then you can see why it is not the same. In Indonesia, so for the ones who are not familiar with cancer, cancer is typically a disease of people who are at least 50 years and above. Actually, 60 and above, but starting at 50. All the younger ones is a rare disease, so you can't forget for the entire picture. And then you can see the difference. Yeah. Here is the old group of the German ones. And here is a small group that you have in Indonesia. But this will change. And then this will show the next one. This will change within the next 10 years. Well, we calculated this. Within the next 10 years, the number of cancer cases in Indonesia will double. By 2030, you have the double number of cancer cases. And that's why you have to deal with cancer right now. You have to start to think about how to arrange cancer care right now. And this is part of this global health coverage. And you have to think, what are the resources that you need? How to get there? What is the development? How is it acceptable to do these things? Acceptable, for example, prevention. You can get the numbers down by preventive programs, but this prevention has to be accepted. So that's why it is so important. And here you can see what we did. So we took the numbers that we got from several publications, official publications, and if you then compare with the demographic development, then you can see that we roughly double within the next 10 years. So this is one of the parts, how to analyze and how to look at such developments, and especially to have a perspective how to arrange. And now you understand why I'm not so happy that Jogsha is doing such a great job, because if more than, if the number of cancer cases is doubling here, you cannot work anymore. So the next one. What are solutions? And this is what we, as one of our partnerships, what we developed, and this is what we provided to your government. We discussed with the Ministry of Health, we discussed these results with the BPGS leadership. And one point is that you need to enable the primary care to do basic cancer care, like the screening programs, like the follow-up programs, like initial examinations and all these things. So, and this requires educated primary care people, especially the general practitioners. They need to be trained. We need a sufficient number, and we need to train them that they know, okay, this is what they should do for cancer care in their setting. And then, and this is the second point, you need to have sufficient numbers of advanced care, and advanced care for cancer means class A and class B hospitals. And these hospitals need to be reserved. They need to be available, but they need to be reserved for the people who really need advanced care. And without showing you the details, right now it is very popular for patients, especially for the BPGS members who are not falling into the PBI support. So it's the non-poor, we call it the non-poor patients, they directly go to the hospitals. They circumvent the primary care. This has several reasons, I understand this, but this is not the way how the healthcare system should work, because then the entire system is overloaded. So bringing A and B hospitals to the regions is also something that is very important. And this is not new, but we can show this with the numbers. The referral system, this is what I mean with the selection. So we need to really select, and we need to find out which patients does need which type of treatment. So is it primary care treatment? Is it advanced care treatment? And this is not a one-time decision. So for complicated diseases, for complex treatment, for surgery, they need to go to the advanced care. And for the follow-up, they need to go back. And then the primary care can take their responsibilities in treating these patients. So going forth and back is important as we call it, referral system. And this is a structure that all countries worldwide, all countries need to establish such referral systems to have an efficient function of their healthcare. And the last one, and this is also very important, and this is what I meant with the acceptance. The patients have to accept what the healthcare system is providing. So they have to accept that primary care has a role in cancer care, and that this is that could be done in a good quality. We have to provide the quality, but the patients also have to accept that primary care is sufficient for cancer care, and you can transfer these things for all others. We have also done this for maternal health and deliveries and these things, so very similar results. So this is the next lesson that we learned from our evaluations. Next one. And now I want to show you one live example that we are just doing, and this is actually the reason why I'm here. What are we doing in not just managing the cancer care, but in getting the numbers not that high as we have to expect them? And one is primary care, is prevention, sorry. One is prevention. And prevention, I will explain you a little bit with the example on cervical cancer screening. So I'm looking around if everyone knows, especially from the non-medical students, if everyone knows what cervical cancer is. More or less, okay. So cervical cancer is mainly resulted by a special type of viruses. We call it the papilloma virus. And the papilloma virus can be transmitted and can be found especially in the younger population. So you are very susceptible right now for getting papilloma virus. One preventive measurement would be to get a vaccination, because there is a vaccination available, and then you will not get a papilloma virus. But you have in parallel to implement a screening which could also be based on papilloma virus detection, because between infection and getting the cancer, usually it takes about 20 years. So we should not wait until the next 20 years and the vaccination is completely working. So in the meantime, we have to figure out what else can we do. And the other thing that we can do, you can see here. We have the very early steps of cancer development. We call it the pre-cancer lesions. And these pre-cancer lesions, actually we can detect, but you need a relatively good qualification to do these things. In Indonesia right now, this screening program that is working to detect these pre-cancer lesions is based on the so-called visual inspection. And this visual inspection is usually done by midwives. Worldwide, this is nothing special for Indonesia. Worldwide, this type of examination has a very low sensitivity and specificity. So we detect not all of the women with these lesions, and many of these women or many of these diagnoses are not correct. So we should look for better types of screening programs. And now this virus comes into place again. And this virus we can detect here, especially in the age here, we can detect this virus. And right now we are investigating. And again, we are doing the very similar investigation in Germany and in the district of Colomprogo right now. This morning we had the official start of the recruitment of the patients. And then you can look if the women are infected. And if they are infected, which is probably about 6 to 10% of the women in this age, then you can send them to further diagnostic, and then you can really provide a little bit more qualified care, and then you can involve the gynecologist. But the number of, you have 5,000 gynecologists in Indonesia, which is pretty low. So you have to select the right woman to get the advanced care, because there is no way to provide the advanced care for all of them. And this is what we are trying right now to implement and to look if this new technology is accepted by the woman, if this new technology is working here in Indonesia, if all the processes around transportation of the samples, the lab diagnostics, everything, if this is working. And this is what we are doing right now in our clinical trial. Next one. Yeah. And in addition, nobody knows right now, or there is very small knowledge, what type of infections are actually prevalent here in Indonesia. Worldwide, this differs a little bit. We have some of the viruses, we have 124 different types of this papilloma virus group. And some of them are very aggressive, and others are, you can actually more or less neglect because they are not causing cancer. So, but we don't know what is the prevalence here. So what is the pattern of these virus infections here in Indonesia? And that's why we are also looking at the same time, we are using lab tests, and they can give us, at least to a certain extent, they can explain us if we find these cancer typical lesions, especially the 16 and the 18. And the others we can more or less right now ignore. And then we know if this is something that is the same as in Europe, for example, or in the US, or if you have a different pattern here in your area. And then we can adjust the screening programs, and this is very important. Now we come back to the affordability, and then we can implement or suggest to the BPGS or to the ministry, this is a way how you can implement a program which still falls into the budget of the BPGS. The budget is limited, so we have to give them an idea how they can use the money in the best way, and this is what we can identify with a program, and very likely next year we will start a second trial, so to even improve these things, and hopefully maybe in the next 2 or 3 years the entire program will change and VIA will not be required anymore with a relatively low detection rates, and we have better ones, and still the BPGS system can pay for it. So this is actually our target. Next one. And here you can see why it is so important. And now we have a different picture. The overall cancer you saw on the initial slides, and here now you can see this. Here you see that in Germany we have pretty low problems with cervical cancer because we have prevention and early detection in place since almost 20 years now. And now we have very low numbers of cervical cancer. This is actually not important in Germany anymore. We still have it, but it's not really important anymore. In Indonesia, corrected for the age, so you adjust for the type of the demographic pyramid. So this is called age-adjusted incidence or prevalence. Then you can see that in Indonesia, the number of cervical cancer per woman or per population is pretty high. And this is the highest number that you have in women for cancer right now in Indonesia. And that's why it's so important to really find a way how to identify these women at risk before they develop cancer. And then we can really treat them, and it's this is one of the cancer types that you can treat very effectively. You can treat in early stages. So if you treat them in early stages, they will never develop cancer. And that's why we are enforcing so much the cancer prevention programs as part of the hospital partnerships. And this is done in several countries. This is done under the same program. This is done in African countries. We know that in Malaysia a few years ago, they also did some investigations. Right in parallel in Cambodia, there is a very similar trial. So you are actually part of a worldwide development which is now going to the low and middle income countries, because this is the new technology is really suitable for countries like Indonesia. The next one, please. Now let's get a little bit back from the cancer program, but to look how we arrange what could be done in organizing the universal health coverage, and what are the keys. And I briefly mentioned already that we are looking for the rural and urban population. We were looking for the poor and the non-poor population, and there are certain criteria, and then you can really conclude, and this is what you can see here a little bit. These are maps where we have 3 categories in 2 different types of classification. And this is again done by complex statistics. And then you can attribute the 34 provinces here in Indonesia to certain groups. And for each of these groups, we can make some suggestions what is important to develop in this province. So in the province of Yogyakarta, I would recommend different things, like in the province of Aceh. And you can, here, this is the distribution. I won't go into the details right now, but this is already published. If someone is interested in these things, you can read it. So this is the way how we differentiate the recommendation. So it's not a recommendation for the entire country, it's a recommendation for each different province. And if you use the same methods, you can do it, for example, in a province, you can do it for districts. So it's just scale it down, use different types of data, but use the same methods. And the same methods we are also using in Germany. And the same methods are used all over the world to address these things and to draw the conclusions. And again, and I know that I repeat these things, I would really encourage you to understand the methods, because then you can do the analysis that you need for your country and for your environment. Next. So here are some of the numbers that I already mentioned, and the most important is this one here. Look, this is breast, and this is cervical cancer. So half of the cancer cases in Indonesia are attributed in women, are attributed to these two types of cancers. And both of them can be treated with early detection and cervical cancer even with prevention. So that's why it's so important. And remember, if we double the cases, then this might be even getting worse. The next one. The problem with the development of cancer care and healthcare in general is that you really have to look at, we call it the process management. So process management means that we really need to know who is doing what and what is a good way to do these things. And process management for the cervical cancer, I mentioned already, this is this EVA test, and Dr. Upi is a specialist, and she can explain these things much better than I can do. But EVA is right now, the standard of care is midwife driven. And midwives, they can be trained in doing a method, but it's difficult to train them in judging what they see. They can really use the colposcope, they can use it properly, that sometimes they do it even better than the gynecologist because they are doing it a lot. But to really look what they see, it's very difficult to train them. And we have to try several new ways. And the next slide, please. This will show you that the alternatives that you actually have. The better way would be it's called the PAP test. So it's a kind of pathological examination. This is much better, and this is standard of care right now worldwide. So PAP test is done everywhere, or supposed to be done. But now we have again the special situation in countries like yours. You don't have the personnel to do the stuff, to do the PAP test. You don't have the qualified pathologists. You need a special qualification to do these things. You don't have the gynecologists who can really do this examination. So we have to find a way. This international standard is not suitable, at least not right now. It's not suitable for Indonesia. So this is not to blame Indonesia, this is a reality. And so we have to find a way, and this is what we try to implement using this new type of detection. The next one. And this new type of detection is related, what we are now investigating, to molecular testing. So we are just taking samples. You can do it either by a swab test. So it's a little brush where you take the mucosa, the mucus you take out, and there you can find some cells, and you can look for the DNA. And the test actually is very similar, or the method is the same for COVID and for PAP, for HPV testing. So the method behind it is the same. So it's available, this type and this technology. You have the machines, and you can do this test. And now we are looking if this test is working here. And in the next step, we would go even further, and we would try to also use an even better or a second molecular test, which can be, if you do both, you can even select much better. Or, and this is the other investigation that we do, we can combine it with artificial intelligence. So the midwives, I told you, they are very, usually they are very familiar with using the colposcope, and then they just have to take a picture. They are not asked anymore, is it suspicious or not? They just have to take a picture. Then we send it to a special computer system, and this algorithm will give us a feedback, and this is what we hope to find, will give us a feedback if this is a suspicious examination or not. And so it's an algorithm behind it. And then the midwife does not need to judge, and she just gets the information. Okay, this woman, HPV positive, and with either the second molecular test or the image investigation is at risk, and then this woman could be sent to a specialist, and the specialist can treat the pre-lesions. There are some methods available to treat these things, and this is something where the resources that you have right now here in Indonesia would cover the entire country. And this is actually our approach. And this is funded by our ministry right now. This is also funded in different areas in the world from other countries. So this is, we call it the global health approach. And next one. And the global health approach is that hospitals and researchers all over the world are joining to find solutions that can be transferred, not just copy and paste. This will not work. But we can try to look what solutions under which conditions would work in this country and this country and this country. And this is what hospital partnership actually means. Next one. So we would share the knowledge about the methods. We would share the knowledge about the new technology, the new molecular tests. We can provide the artificial intelligence algorithms, because you probably better know than I do. Data can be transferred very easily, and you can send it to a central computer system here in Indonesia, and they will do everything. And so this is one thing that we can share. Next one. Then we ask the midwives to do the colposcopy. Next one. And do the additional test, and then we can really identify here the woman at risk, and the number of women that we really need to treat is probably only 1 to 2%. And so we cut down the number of women that we really need to use the system. We cut down by the factor of 50 to 100. And now you probably understand why it is so important to look for such solutions that are suitable to the systems that you have here. It's suitable to the resources that you have, to the qualification levels that you have, hopefully to the affordability. We don't know exactly how expensive this will be in the future, so this is one part of the examination. But this is what we really do, and as I mentioned already, this is done in many, many countries right now worldwide, because cervical cancer is a preventable type of cancer. So this is, we cannot eradicate completely, but at least we can narrow down it to a cancer which is called a rare cancer type. So in theory, this is achievable. The next one. And hospital partnership means that we have to bring together partners from different countries. Because here in Indonesia, you know the problem. Here in Indonesia, our partners know or have an idea what are acceptance problems. but they don't have experience right now with the new technologies. So they don't know right now how to organize these new technologies, and then we came into place, and so we discussed many things together, and we brought our experience here, our knowledge about the methods, and our hospital partners here, they brought their clinical experience, and they know the environment here, and they know the culture here and everything. So this was brought together, and we still bring it together for the next steps. And then we can jointly develop such programs, and you see how many partners we involve. We have 2 partners here actually we have 3 partners. We have 2 universities, and we have the district. The government, the local government is supporting this trial. We have the University of Indonesia and the Damais Cancer Center for the next steps, because the evaluation of all these data is very complex. So we need some specialists here. We will also involve Damais to compare Jakarta region and Yogyakarta region to really have a national program and a national understanding. And you can see here all these partners from the universities in Germany, and someone has to fund this type of research, and this is showing here. And hospital partnerships right now, since about 4 years, I think, we started in Germany, a special program started, which is called the German Alliance for Global Health Research. So we have a special governmental program to do exactly this type of research and development in a joint approach with other countries, especially with the low and middle income countries. I think this is probably the last one. Yeah, before I give you the chance to ask some questions, I want to share, or I want to avoid the impression that cervical cancer problems are only important for Indonesia, and that I am here and just telling you what to do. The next one, we have also, it is much smaller, much smaller. We also have a problem with cervical cancer, and these are the groups that are not taking, or that are not accepting all our programs. All the prevention programs, all the early detection programs are included in the insurance coverage. But next one, look here. The acceptance, or we call it the usage rate of these programs, is not optimal. Here you can see that age is a problem, and the women are doing better than the men, as always. So age is a problem, and education is a problem. Certain groups we do not reach, especially the groups with lower education. Certain groups we do not reach, especially the men. Here, look at here. The younger men and the younger women are doing really better. So we really have to think about, we call it the cancer literacy. Cancer literacy means that the population is aware of the burden, of the danger of cancer, and that in your age, probably nobody, maybe if you have some cancer cases in the family, but nobody in your age would really assume, okay, cancer is something that can hit me. This is normal, but we have to educate, we have to explain. You are right, this is, right now it's not really important, but if you are not dealing with it today, in 20 years, you will have the problem. But 20 years for you, for your age, is a long time. And so that's why cancer literacy is something that is also very important as a national topic, to educate the ones that we are not reaching right now, that are not accepting what we are doing. And we have to understand why. What is the reason? Just to explain, okay, low education, they don't know, this is too simple. This is part of it, but this is not the only one. This has, as I mentioned in the beginning, this has some cultural barriers. This has some accessibility barriers. And all these things are coming together, and we have to really understand and to address that the ones who we are targeting are really accepting what we are doing, and that they really use all these offers. The next one. So determinants of this vulnerability, we call it vulnerable groups. This is the language. This might be important. I don't know exactly if a language issue is important in Indonesia. For us, with all the migrants, we have a language issue. They have to understand what I'm talking about. We have the culture, we have the religion, we have education, but we also have social factors. And this is something that we expect is very important here, that, for example, the village leaders in the rural areas or the religious leaders, they have to support this program. If the leaders are against the program, the woman will not go. If the husbands are saying, are you crazy? This is nothing that I accept for my wife, the woman will not go. So we have to really explain them and to really target also the social environment in this cancer literacy. And this is something that we want to develop together. And this is not new for us, and this is not new for Indonesia, but we need to find ways to target it. Next one. Yeah. The implementation barriers, this is the approach that we try to do together. And next. So we want to bring the patients that are seeking for healthcare together, next one, with their factors and accepting that we have vulnerable people, and we have to find out what are the best solutions. And so here they are seeking for healthcare, but they are not accepting it. Next one. Next. And these are the factors that also determine the vulnerability. So this is a very individual problem, a very subjective problem, but you can do research on it. And I would be really happy if you would, at least some of you would join the research in this type of topic, and at least that you understand this type of research. The next one, and next. This we can skip. Next. Yeah. The last point, and now it's, I think it's my last slide. The last point is regarding the affordability. I was talking a lot about resources and all these things, but affordability also means not only the direct costs to pay the physician or to have related coverage of the insurance, but we also have affordability in a different manner. The next one. The patients have to pay for many factors. They have to pay for the treatment, but they also have to pay for the treatment. They have to, usually if you are sick, your income is getting down. If you are sick, the family income is going down because some of the family members have to take care, and they are not, they cannot work as usual. So this is something where the entire social environment is involved and is suffering, if we call it the financial burden. And this financial burden is something that happens in all countries worldwide that were investigated in this regard. I have some numbers in Germany. The average drop in the family income or in the financial efforts is about 20% if a patient gets cancer. 20% of the family income if a patient gets better. So this is the drop. I would assume there are no data available, but in other low and middle income countries, this drop is about 50%. And probably in Indonesia, we should assume that 50% of the income is going down if someone is getting cancer. And this vulnerability is something that we really take or need to take into account if we are talking about a general solution and if we are talking about acceptance. So not only the direct costs, but also the indirect costs are very important in this regard and need to be addressed. And this is again something where you can exchange experience between the different countries. The next one. Next. We will skip this. Yeah. And this is a kind of summary that I want to share with you. If you are talking about hospital partnerships, you are talking about universal health coverage. You are talking about a problem that happens in all countries worldwide to a different extent, but you have the same problem everywhere. And the target is to get the best, not the best, the optimal treatment. The optimal treatment at the, to the patients that really need this treatment at the right time and at the right place. So this is everything that you have to arrange, and you have to arrange, especially in a collaboration between the medical students, between the nursing school, nursing students, between the economists and everyone. So this achievement here, the right patient at the right time to the right structure, this is the challenge that you, that my take-home message is, that you really should keep in mind that this is the responsibility of all the participants, all the stakeholders in the system of healthcare management. So I hope it was not too much confusing, especially in the beginning. So thank you very much for the attention that you paid, and I'm really happy to take some questions.
Thank you very much for a very impressive presentation. Several times I always heard from Professor Hayer, but never boring. And I would like to invite all of you to deliver the questions, if you still have the question to Professor Hayer. Yeah. No need to be uncertainty with the meaning, because we would like to also translate if you want to deliver in Indonesian language. So everything is clear for you? Clear? So you don't have any question? Or you want to propose something to Professor Hayer? For example, can I join with the research like this? Because actually we will continue for the second round, yeah, Professor Hayer. And we would like to conduct in Indonesia, in Jakarta. Or if you want to join with us in Kulon Progo, because it will be still 1 year until next year. Do you have any question? No? Okay, so I think because right now is the time for them to go back home. Oh, okay. Yeah. Can you come here? Because it's very far from your position. From which program? From their program?
Okay, thank you very much for the chance. My name is Alfia Amalia. I'm from the Department of Pharmacy, batch of 2019. And here I would like to ask a question. Before you explain about the acceptance of the society to healthcare programs, and as far as I've seen or observed in the society, one of the things that cause it's hard to people to accept the healthcare programs is the spreading of fake news or hoax. Especially in Indonesia, it spreads so massively around the society, and it's even happened to my family. And sometimes even if as healthcare students we explain it to them, we don't even believe on us, because they prefer to accept the fake news, and it's, I don't know why, but it's more acceptable for them than the medical information that we provide. And my questions to you is, do you maybe facing the same problems in Germany, and how do the Germany government or maybe the system, the healthcare system there, to deal with this kind of condition in the society? Thank you very much.
Thank you.
This is an excellent question. And I will answer the second part first. We do have the same problem in Germany, but maybe a little bit different regarding the type of problems that we have. But providing bad news to the patients is always a real challenge. And this is what I actually mean with cancer literacy and culture. In some cultural background, it's a little bit more difficult to provide bad news. I know that I have personal experience with some cultures where it is completely prohibited to talk about dying. So if you are not talking about dying, you cannot provide palliative care. So it's very difficult to handle these things. And this is part actually of the development, the cultural sensitivity of the systems that you need to develop. You need to think about and to do research. How can we deal with this type of neglectance? So if the patients, how can we convince them to believe in these things? What are step-by-step solutions? And so communication training is part of the solution, and this is what we try to implement for our students. Right now we have programs running where we involve patients, so the patient self-help groups, that they can provide, because they are involved themselves, and they may have a better chance to transport such information. So we try to use different ways. There is no one solution. So we try to do different ways and to develop them and to educate the patient representatives that they are able to get in such a communication. So this is what we call it the outreach program right now, to involve the other types of communication.
Yeah, so it is clear, yeah, for you? Okay. And maybe the other participants, do you have the question to Professor Hoyer? No problem, yes? No? Oh, okay. So, yeah, thank you.
Yes. Thank you for the lecture, Professor. I would like to ask you about, is there any program in primary care in German about cancer, especially, that's suitable and applicable in Indonesia, especially in primary care Indonesia, just like you said, in puskesmas. Thank you.
Very good. So, are you from medical student? Oh,
This is also a very good question. And the very clear answer is, we have nothing that you can copy and paste.
so do not copy and paste.
My message is, do never copy and paste. This will not work. So what we have in place in Germany, we have experience. And we learned some lessons. We have 130 years of insurance. So you have 5 years, 6 years right now. So we have a long history and a long experience. We gained a lot of experience regarding what could work and how it's working. But we always try to explain you, we can provide you with the tools. So our experience as tools, not as solutions. And the tools that you can develop your own solutions for Indonesia. We can assist and give some advice to ask the right questions, but we will not give you solutions. And this is something different. If you're asking American professors, they will always explain you, we have the solution, you just have to use it. In Germany or in Europe, we are convinced this will never work.
Actually, in Germany, they always give us about some overview, best practice, and also give good advice. And finally, we have to build our system by our own self, because it will be very reliable with the condition of our country.
Especially if we just copy and paste, you are relying that I will be here. And I mean, I really like Georgia, but my town is in Germany. And sometimes, even if I will be here very frequently, sometimes I will retire. I mean, you can see my gray hair. And so if I am gone, what then? That's why we always propose you have to develop your system to be sustainable. And we can assist you. And if you are, the best would be if you next year could say, we don't need you anymore. Then I did a good job.
Okay, yeah. Okay, any question? So it's quite enough for you? Okay. So once again, thank you very much, Professor Haya, for sharing and giving your expert lecture in front of our students. And give the applause to him. Actually, we looked at almost 100 at the first time for the participants online, and thank you very much also for the participants who joined online for today. And I think we don't have any ceremonial again. So thank you very much for attending this occasion, and we will meet again maybe for the next year. And thank you very much. Or maybe Dr. Mahe, you want to give the speech? Okay. So let me close together by Hamdalah. Alhamdulillah. I think one is will be very memorable if we make the pictures together, right? Okay. So let's see. Yeah. Here, yang tinggi, yang tinggi. Do you know yang tinggi is when who is the tall one? Because we'll be beside you. Ayo. Dr. Mahir is the head of the operation of medical faculty. Yeah. Okay. Ayo foto-foto. Oh, siapa yang punya kamera bagus? Siapa yang punya saya cuma flip soalnya. Oh ini dia. Siapa? Yang punya bagus.